Hello, welcome to Coffee Time again with Mike and Janell. Today we're going to finish our discussion from last week regarding polypharmacology, which means when someone is being prescribed multiple medications. This can cause a lot of issues, and we oftentimes see patients have multiple medications, huge medication burdens when they come to us. And I want to have a little bit larger conversation with Dr. Cummings about why this can be problematic.
Of course. So as Janelle said, polypharmacy, being on multiple medications, is very common in psychiatric conditions, and specifically in individuals with developmental disorders or autism who also have comorbid psychiatric conditions. So they have autism and maybe they have ADHD or bipolar disorder, or maybe they're just symptoms of autism. The problem is all medications can be helpful when they're prescribed the right way to the right people. But even if a medication is very helpful, it still will have side effects. As you add more and more medications, those side effects can combine and double and triple in size, or the side effects can make one of the other medications not work as well. So anytime someone's on multiple medications, that's a concern. They can worsen other medical conditions, whether they be psychiatric conditions or things like asthma or seizures or other things that our population has, GI problems, for instance. There's also a cost. A lot of people don't realize because insurance and Medicaid cover the costs for most of the people that we see, but not everyone. It's very easy for someone to be on 3 or 4 medications that the monthly cost out of pocket would be well over $10,000 a year. Now, if your insurance covers that, maybe that's not such a big deal to you. But when you think about the fact that 1 in 54 children have autism right now, when you multiply that out, that's a huge burden to our healthcare system. And last, there's a phrase that Janelle and I coined talking about institutionalized prescribing. And what that means is when people live in institutions, group homes, hospitals, residential settings, there's usually a nurse who hands out those medications. Medications come in a packet, a blister packet. And so you can relatively easily give out a medication 2-3 times a day, multiple medications in different combinations. That's far more difficult to do in a home setting. And so when we talk about polypharmacy, we're not just talking about multiple medications. We're also even talking about individual medications being given multiple times a day, when very often they don't need to be given multiple times a day. They can be given simply once or twice a day.
Yes, yes. And just going back to side effects quickly, I mean, many people who are on medications can verbalize, that they're feeling discomfort or they're having, this sensation that, is causing issues for them. But a lot of folks that we work with are not able to articulate
Absolutely.
such. So can you just explain to us a little bit further why and how this type of prescribing occurs with the multiple medications on these folks?
Well, in episode 3, we talked about the importance of an accurate diagnosis and how difficult that can be. A lot of polypharmacy comes from the fact that people, physicians, nurse practitioners, physician assistants, are prescribing medications based on symptoms and not diagnosis. So, for instance, to talk about a psychiatric condition such as bipolar disorder, there may be psychosis, there may be insomnia, there may be physical side effects associated with other medications, and often people will be given 3 or 4 medications, one for how they're thinking, one because they're not sleeping, one because of side effects, one because of anxiety, when all they have is bipolar disorder, and that could be treated with 1 or maybe 2 medications. So diagnosis is super
Yes.
important. Individuals on the autism spectrum, 1/3 of whom have seizures. So very commonly, there is a psychiatrist, a primary care physician, as well as a neurologist treating an individual. And unfortunately, many times, each of them are prescribing medications for the same thing. Communication between all the providers is crucial. Very often, you may have someone who has autism and bipolar disorder and a seizure disorder, and they're getting meds for bipolar disorder and they're getting meds for a seizure disorder. And if you have the appropriate communication between the psychiatrist and the neurologist, you may be able to take 2 meds and turn them into 1 and have the same outcome.
Yeah.
So communication between the providers is incredibly important. One of the trends for psychiatric care, unfortunately, and we could talk about this a lot, but I won't belabor the point right now, is that much of psychiatric care is done in very brief medication checks. It's not uncommon for a medication check in a psychiatric office to be under 10 minutes. I would argue that that is difficult to do with neurotypical individuals who are completely verbal and can express all their feelings, concerns, emotions out loud. When you're talking about the population that Janell and I treat, where very often that's not the case, in a 10 to 15 minute med check, there's really nothing you can do other than add medications, subtract medications, increase medications, decrease them. And so that lends itself to the appointment being about medications only. And we know when we're talking about autism and other developmental disabilities, there are so many other things that go into it other than just symptoms and medications. But those brief medication checks really lend themselves to polypharmacy in a very, very big way.
And oftentimes if the individual is having problems with transitions or leaving the house or on the car ride, overstimulation in the office, they may be presenting more aggressive or irritable when they come into the doctor's office, which is just going to lend, to the presentation of having a medication increase, be warranted. So what would you suggest are some strategies to help with really lowering the medication burden?
Well, at a very high level, and in the future we'll go into more specific strategies, but at a very high level, the most important thing, there needs to be a medication plan.
Yeah.
There needs to be a treatment plan, but a medication plan that is openly discussed with the family and with the individual being treated if they have the capacity to actively engage in that conversation. And when I talk about a medication plan, every time you start a medication, there should be a full discussion of what you expect the benefits to be, what you expect the time frame of those benefits to occur in, what you expect the side effects to be. There's many other things to talk about, but those are the three main.
Mm-hmm.
If you start a medication and it's not being helpful within the time frame that we expect, then you really need to rethink what your next step is.
Yeah.
If you are having side effects of a medication that greatly outweigh any benefits you're getting, then there needs to be a conversation about that. So having a medication plan so you know the roadmap of when to start, when to adjust, when to stop medications is crucial. The other thing is, and again, we can talk about more specific details in subsequent episodes, is whether you have autism, whether you're intellectually disabled, whether you have a developmental disability, whether you have a comorbid psychiatric disability, you still have the right to have a bad day, a bad week, a bad month. We all have struggles. We all have things that happen to us internally and externally that may result in disruption.
Yeah.
That doesn't mean that you need a new pill for that. It's very difficult, particularly in the nonverbal population, to tease these things out. But we also have to remember that as our autistic children are going from infancy to toddlers to kids to teens to adults, etc., that they're navigating the same struggles the rest of us are struggling in our life. And we want to be really careful to not add a medication simply because they're going through a brief period of disruption, just as any of our other children may be going through.
Like a teenager being a little pain in the...
Exactly.
Yeah,
I mean, I frequently will tell people that having had two 14-year-old boys, 14-year-old boys can be jerks. And that doesn't necessarily mean they need an extra a pill for that. And the fact that your 14-year-old boy may be a nonverbal boy with autism doesn't change the fact that things he or she is doing may just be normal developmental things and not requiring further medication.
I gotcha. So I think we covered everything. So in the next few episodes, I think we really want to talk about specific side effects that are commonly seen with psychotropics that are used in this population. So we can delve into that in the next few weeks, and we look forward to seeing you.
And as always, if you have specific questions about your child or young adult or adult individual with autism or other developmental disabilities, please reach out to your primary care provider, your psychiatric provider, and you can always reach out to the APEC team at apecout.org with general questions. and hopefully we can guide you in the right direction to have yours and your loved ones' needs met.
Yeah,
Okay.
sounds good.
Till next week.
APEC out.